We are presenting our technique for humeral head bone grafting of a large Hill-Sachs lesion using osteochondral allograft through a percutaneous posterior approach. These are our disclosures. This was a 17-year-old male patient who is an elite-level snowboarder. He has a history of multiple dislocations, hypermobility, and patellar subluxations. He experienced his first shoulder dislocation at 15 years old, which was treated with an arthroscopic labral repair. He had a postoperative recurrent dislocation that was treated with a revision anterior labral repair and an arthroscopic remplissage. Since this surgery, he has had multiple recurrent instability events. On physical exam, he demonstrated a Baton score of 7, full forward flexion, but he had pain past 90 degrees of flexion. He had limited external rotation and abduction with pain past 90 degrees of abduction. He demonstrated positive apprehension and anterior draw tests, and he has full muscular strength without any atrophy. The MRI and CT scan show a large Hill-Sachs lesion on the posterior aspect of the humerus and a large anterior glenoid defect that was addressed with an open Latarjet but is not depicted in this cadaveric replication of the clinical case. The patient is intubated and placed into the beach chair position using an upright positioner, allowing 270-degree access to the shoulder. First, a diagnostic arthroscopy is performed in order to confirm the engagement of the Hill-Sachs lesion and eventually address other concomitant pathologies. A 5-centimeter incision is made at the posterior lateral acromion, just lateral and distal. This incision is made in the midpoint between a direct posterior and a direct lateral incision. A deltoid split is made in the posterior raphe. The subdeltoid space is then expanded by digitally sweeping away the bursa. At this point, the Hill-Sachs lesion is easily palpable deep to the infraspinatus muscle and tendon. The fibers of the infraspinatus are then split in line over the Hill-Sachs lesion, and Z retractors are placed under the cuff for good visualization of the humeral head. The Hill-Sachs lesion can then be measured in all 3 dimensions from CT or MRI and arthroscopy in order to determine the correct allograft plug dimension. The bone plug size is determined using the appropriate cannulated allograft Oates sizer. The sizer, anywhere between 8 and 20 millimeters in diameter, is then placed over the allograft condyle to ensure the allograft is large enough for the defect site. The authors prefer to use fresh osteochondral allografts from a femoral condyle. Once the appropriate size match has been confirmed, the recipient site is reamed to the desired depth of the recipient site. This is generally a 1 centimeter depth. Then, the appropriately sized allograft Oates dilator is used to achieve a 0.5 millimeter socket dilation. The donor graft is prepared on the back table with the large osteoarticular transplant graft preparation system. After securing the donor allograft in the allograft Oates workstation, the previously chosen sizer is placed perpendicular over the graft. It is critical to choose the part of the graft with a convex articular surface, thus allowing to restore the native convexity of the humeral surface. The graft is then harvested to a depth of 15 to 20 millimeters and then removed. A dedicated allograft Oates holding forceps is used to secure the graft, and then an oscillating saw is used to slowly trim it to achieve the correct depth previously determined on the recipient site. Marrow elements of the cancellous bone are minimized using 3 liters of antibiotic pulse lavage. Once the recipient site is irrigated, the graft can be manually placed into position and with light impaction is inserted into the recipient bed. The allograft plug, when it is well prepared, must fill all the medial to lateral as well as the depth of the lesion, resulting in a stable bone plug that does not need any other fixation. However, a headless compression screw, 2.5 millimeter, can be used in the center to secure the graft. The wounds are then irrigated, and the posterior infraspinatus split is closed with high tensile strength number 2 sutures. The deltoid split and more superficial layers are closed with absorbable sutures in layers. The postoperative arthroscopy demonstrates smooth internal and external rotation without any engagement. The allograft has an interference fit and is inherently stable, so there are no additional restrictions. Patients will follow a typical Latarjet or arthroscopic labral repair rehabilitation protocol, where anterior capsular stretch is restricted for the first 12 weeks postoperatively.